So I thought since we can all get on, so that we can all get on a little bit of a level playing ground, we should talk about just an overview of the procedure. So when we talk about sacral neuromodulation, there's really two techniques to accomplishing this. The first technique is called a stage lead placement. This is what you'll typically see performed in our practice at Northwestern. This is going to require 2 trips to the operating room for the patient with a stage 1 and a stage 2 that we'll get into. And then there's something that we refer to as a P&E, which is a percutaneous nerve evaluation. For this procedure, that first aspect of the test is done with a different little test wire, which is a teeny bit more flimsy, I guess. It's a temporary wire. So literally the first aspect of this, we're going to place in the office this tiny temporary wire, tape it down, get it secure, and test this aspect for a couple days. So we might test them for 3 days before we decide whether or not this is going to warrant implantation in, a complete staged fashion in the operating room. So the important thing to know about is that the lead that's placed during that test phase for a P&E is not the lead that's ultimately implanted in the patient. So in terms of our 2-stage procedure, this is a little diagram that's kind of showing that first stage. So the first stage, you can see this wire that's entering the S3 foramina right here. That's what we're going to be testing. It's connected to this external device, and these look a little different now. This was the older device, but it's just got this little external connector that's going to be allowing us to do the test phase. And this is how we're going to accomplish it in the operating room. We use a teeny tiny little needle. The patient lies on their tummy, and we're going to be putting that needle in right next to the nerve, and then we'll slip the wire in to be accomplishing our test. We talk about this a lot, what the proper lead placement is. This is in the operating room, we're always utilizing X-ray or fluoroscopy to make sure that we are in fact in the right area. There are a lot of bony landmarks that people have effectively utilized to ensure this, but we would like to make sure before we finally implant somebody. And this is a diagram of someone, again, lying in that same position. This is a lateral view. You can see the tailbone right here. It's hard to see on the screen right now, but there's this little shadow that indicates underneath the shadow is where our S3 foramina should be. And we want to always have the lead in so that we talk about these 2 electrodes, these 2 most distal electrodes straddling the bone table. And this is a PA view here. So again, we see the lead, and the lead is doing this little hockey stick out laterally, and that just makes us think that the lead is following the nerve and we'll get the highest or best amount of stimulation or contact. So I talked a little about the S3 foramina. The reason we target the S3 foramina is because this is what's providing the most amount of innervation to pelvic organs. So Tom Benson, who is unfortunately passed away, really was one of the pioneers in sacral neuromodulation and high quality research in urogynecology, is someone who really did a lot of early investigation and determined that S3 is really providing most of the innervation to the pelvic organs. Typically, when we're in the operating room, we'll try to evoke motor and sensory responses. Most often, you'll see us evoking motor responses. So the motor responses that we look for are bellows, which means contractions of the pelvic floor muscles, and flexion of the great toe. There are some things that we like to avoid seeing that indicate we're in the wrong area. So if you see a lot of pelvic floor response, that could mean you're in S4. And if you see lateral rotation of the foot, that typically means you're in S2. So there we can gather a lot of information from the different motor response that we see when we're stimulating. In terms of sensory responses, these are also really helpful. You'd want to basically make sure that the patient's feeling the stimulation almost in the bicycle seat area. So we talk about the bicycle seat area, which really is referring to the perineum for women. We used to wake people up to ask them where they're feeling the stimulation, and sometimes still do when it's difficult, when we're having a difficult time seeing the motor responses. But I would say that in our practice, we're less likely to be waking people up, just given the additional complexity in providing anesthesia.